So sorry guys, sorry for the interruption. So I'm like due to some technical errors, so it became some late. So please excuse us. So now I think everything is fine, right? So now everything is fine, I think so. So let me wait for 1 to 2 minutes so that you guys can join. Sorry for the delay, like due to some technical errors, we could not join. I think my voice and my video is fine, I think so. So if everything is fine, please thumbs up. So sorry for the delay. And my video is fine, I think so. So if everything is fine, please thumbs up. So now you can join the class now. So sorry for the delay. And my video is fine, I think so. So if everything is fine, please thumbs up. So now you can join the class now. So if everything is fine, please thumbs up. So now you can join the class now. So let me start the class. So if everything is fine, please thumbs up. So now you can join the class now. So let me start the class. So you can comment in the chat section. So let me start the class. So you can comment in the chat section. So you can comment in the chat section. So you can comment in the chat section. Okay, I'm starting the session. So I think everything is fine. I'm starting my session now. So like this is the most important topic for your exams. Like now recently they have updated the neonatal resuscitation also. So let me begin my discussion today. So in this session we are going to discuss about pediatrics, which is a very important topic, and now let's complete our series of an pediatrics, and next we move on to like subsequently we'll be solving our MCQs, and next we move on to the other subjects also. So I will be explaining like each and every topic which is related to your NORCET exams, like very important topic, must know topics, like you should know these topics before going to the exam. Like please don't forget to study the topic. So let's begin our discussion now. Like neonatal resuscitation, what do you mean by this neonatal resuscitation, how does it work and all. So let me start up my discussion. Like what do you mean by this neonatal resuscitation? So what, does all the babies need any resuscitation? No, only less than 10% babies they need resuscitation, they need some resuscitation. Okay, and next when you come to this positive pressure ventilation, only 5% babies they need your positive pressure ventilation. Okay, and how many babies they need chest compression? Only less than 1% they need your chest compression or medications, right? These are all about some basic points. So like, let's move on to the main course. Like what it is going to show in neonatal resuscitation is like, you guys have been seen this diagram, I think so. Like if you are not seen also, like let me explain this diagram. So I think it is very difficult for you guys if it could be like this. So let's discuss what are all the points that we come in neonatal resuscitation. Like, so neonatal resuscitation, like what are all the points you will see over here. So I will simplify this table for you. Like, so before birth, so what you are going to see in the baby is like before birth you are going to do this, no, antenatal counseling, okay, and next is team briefing, and next is equipment check. Okay, these are all the things which you are going to do before birth of an baby. Okay, so antenatal counseling, you are going to counsel the mother, like what are all the, you are asking the mother like what are all the risk factor associated, whether she is having an hypertension or a not and all, right? So this you should ask the mother. So generally antenatal counseling is done by pediatrician, but in our country most of them hospitals pediatrician won't be available. So like OBGs or residents, or they only will be doing this antenatal counseling. And team briefing, like you have to introduce yourself and who are all the staff they are present with you in your team and all. Like equipment check, what do you mean by this equipment check is whether the sufficient endotracheal tube is present with you, or what size of an endotracheal tube or what size of an suction catheter is there with you. This is known as the equipment check. Okay, so these are all about three components which are going to do before the birth of a baby. And now after birth, no, baby birth has happened. Like after birth, what you are going to do is you are going to look at this like TTC, that is term, tone, cry. These are after birth. So what do you mean by looking at the baby only? You can tell like whether the baby is a term or preterm or postterm and all, right? Like after looking at the mother file, you may able to know whether it is a term pregnancy or preterm pregnancy or postterm pregnancy. And tone, what do you mean by the tone is like whether the baby is having the good movements or good flexion, extension and all, right? What about cry? Like this you can see, no, like whether the baby is crying or not by through looking at your eyes only you can see whether the baby is crying or not. Okay, and if everything is there, the baby is term pregnancy and tone, the baby has a very good tone and the baby is crying, then everything is S, then you go for routine care in the baby. Then go for routine care. So what do you mean by this routine care is like you have to dry the baby and you have to provide warm environment to the baby, because newborns may go to the thermogenesis, no, like they go to neonatal hypothermia. So that's why you should provide warm environment to the baby. Warm environment to the baby. Okay, and if everything term, tone, cry is not there, if it is not present, no, then what you are going to do is you have to go for these initial steps. So what are all the steps? So your baby is not crying, and if the baby is term not preterm, and if the tone is also not there, what you're gonna first do is like same, like you have to provide warm environment, and you should, so that's why providing warm environment, it will maintain temperature. And next is you have to position the airway. Okay, and next clear the secretions. You have to clear the secretions in the baby. Okay, how? By through the suction. By suction. Remember the order of the suction is first mouth and next is nose. Okay, so this is the order of a suction in the baby. So remember, like you did not to do suction for all the babies. Suction if required. No, you need not to do like routine suction to the all the babies. And next is like you have to dry the baby. And very important, if the baby is not crying, if the tone is absent, and if all these above three conditions is not satisfied, you have to stimulate the baby. You have to stimulate the baby. Okay, so how do you stimulate the baby? So you are going to rub the back. This is very important step. If the baby is above all the options is no, if the baby is not crying and all, like you have to stimulate. How you will stimulate? By rubbing the back of baby, okay, or by tickling the sole, or tickling the sole. Okay, so this is very important. And if everything is done, then also like you found the baby is apnea, if baby is not breathing properly, right? Apnea is nothing but temporary cessation of the birth. Okay, and you may find gasping in the baby. Okay, the baby is apnea or gasping, right? And if baby apnea is not present and gasping is also not present, then you may find the baby is having this labored breathing. There may be a labored breathing, or there may be a cyanosis. Okay, the apnea is absent, gasping is absent, so even though the baby is not well, then you are to evaluate for either labored breathing or cyanosis. Labored breathing is nothing but your RDS, respiratory distress, if the baby is having this respiratory distress or not. In that condition, baby has labored breathing and the baby has the cyanosis, you tell yes. If this is present, then start the supplemental oxygen. You are going to give the oxygen to the baby, and next you are going to monitor the child, and next is consider continuous positive airway pressure, CPAP. Like you are giving this continuous airway to the baby, but you are not sealing it completely, you are giving by the oxygen, by through the oxygen tube. So I will be explaining in my later slides also. I have the pictures also for you. And if the baby is apnea or gasping, yes, and check the heart rate. Very important. If your heart rate of the baby, normally it is between 120 to 160. If the heart rate is less than 100 beats per minute, okay. If the heart rate of the baby is less than 100, then what you are going to do is you have to going to give positive pressure ventilation. So how do you give this positive pressure ventilation? By using bag and mask ventilation, no, ambu bag. I will show you the diagram also. First we will go to these concepts clearly, so then I will be teaching about the how to use this ambu bag and all. Like, and next look at for the SpO2, and next monitor ECG, connect your ECG leads to the baby. Okay, next apnea is present, gasping is present, and your heart rate is less than 100, you are going to give this positive pressure ventilation. And after that also I gave this positive pressure ventilation by through the ambu bag. After that also my heart rate does not improve, my heart rate is less than 100 beats per minute. Now what you are gonna do is like, yes, tell me. Now what you are going to do? Check for the ventilation corrective steps. Okay, you are going to check for the ventilation corrective steps. So what are all the ventilative corrective steps? What do you mean by that is MR SOPA. So remember this mnemonic. What does the M stands for? Mask adjustment. Okay, and what is this R stands for? Reposition the head and neck. Okay, and what does this S stands for? Suction if needed, not routine suction. So order MN, mouth comes first and N comes last, no, so that's why mouth and nose later. And O stands for open the mouth, and P stands for increase the pressure. So I will be teaching how much pressure you should be giving and all. Pressure increased. And what this A stands for? A stands for alternative airway. So what do you mean by this alternative airway is like you are going to give this endotracheal tube and laryngeal mask airway to the baby. Okay. So this, and now you have, remember these steps are very important. So if everything is fine and after giving the oxygen my heart rate came above 120, 110, or my heart rate came to the normal value in between 120 to 126, then we are going to do the post resuscitation care. Okay, very important. And next is like after giving I followed all this, whether the mask should cover the mouth and nose and all, right? So both the mouth and nose, and like I have repositioned the child head and neck, and I have did the section, and I have opened the mouth, and after these steps also my heart rate is decreasing. Now my heart rate is coming how much? Less than 60 per minute. So in that case what you are going to do is like intubate the baby, intubate the child by through the endotracheal tube. Okay, and next heart rate is falling less than 60, I have to start my chest compression, and I should give this 100% oxygen to the baby. 100% oxygen should be given. Okay, and you have to do ventilation. I am providing ventilation and compression. So it doesn't mean that just I am just giving the compression, you should neglect the ventilation. Both there should be a coordination, there should be present between the ventilation and compression. Okay, so there should be a coordinate. So I am giving this chest compression, and one more, my friend he is helping me to by using this ambu bag artificial breathing. No, so that's why you are ventilating and you are compressing. Okay, so and this you should do for 30 seconds. Then also my heart rate is less. Then what at last what I are going to do is I am giving the drug. So the drug is give epinephrine. Okay, so by giving the epinephrine also you have to continue the positive pressure ventilation plus chest compression. Okay, so there have been some changes in the neonatal resuscitation. I will be teaching you that also. And rule out for this again, my heart rate is less than 60, then you have to rule out for hypovolemia. And this is about basic. So everything what I have taught you is in this table itself. So this table will be a bit confusing. So let me briefly summarize what you are going to do before birth. So now the baby is not born. So what you are going to do is like antenatal counseling and team briefing, and you have to check for the equipment, whether the equipment is functioning or the not. And after the birth, baby has born, then what you are going to do is term tone cry, TTC. Everything you have to look whether the baby is a term baby, tone is present or cry. And next you have to, everything is present, then you have routine care. What do you mean by this routine care is you have to dry the baby and you have to provide the warmth to the baby and all, right? And if the baby is not crying, everything is absent, then you have to provide this warmth and you have to stimulate. Main thing is stimulate the baby. So how you are going to stimulate the baby is like by tickle the sole, or you have to rub the back of the baby. Okay, and this is, and after that I check my heart rate, my normal heart rate 120 to 160, and if my heart rate is coming less than 100 per minute, then what you are going to do is like I have to give this positive pressure positive pressure ventilation using this bag and mask ventilation, and I will attach SpO2 and I will attach my ECG also. And after that also my heart rate is less than 100, then you have to check whether your positive pressure ventilation is correct or not. Okay, if my positive pressure ventilation is, how you are going to check? Mr. Sopa is the mnemonic over here: mask adjustment, reposition, suction, open the mouth, pressure and alternative airway. Okay, and next my heart rate is getting less than 60 per minute, then what you are going to do is intubate the child and chest compression and give the oxygen. Okay, after that also, after I have did everything, I started chest compression, and even though my heart rate is less than 60, I gonna give the drug to the baby, that is like epinephrine. So give epinephrine to the baby, that is continue the positive pressure plus chest compression, and everything is done. So dosage of the adrenal I will be teaching you in the short duration. So these are the steps. Okay, so all these steps you should go by the step by steps, don't jumble it. So I have simplified for you. So if you have any doubts until here, you can ask me. So if you have any doubts until here. So I think I will proceed with the next one. So let's start with this. So I taught you know like at what time, like how much oxygen you should be given and all. So let me teach you like at 1 minute how much oxygen, right? So remember at 1 minute how much oxygen you are going to give the baby. So I thought you know you have to give the continuous positive airway pressure or oxygen to the baby. At 1 minute how much you are going to give is like 60 to 65%. Okay, at 2 minutes 65 to 70. So if your SpO2 value is less than this, you are going to give the oxygen to the baby. Okay, like you have monitoring the SpO2 over here. So 3 minutes 70 to 75%, at 4 minutes 75 to 80%, at 5 minutes 80 to 85%, at 10 minutes how much oxygen you are going to give? 85 to 95%. Okay, this is about how much oxygen you are going to give to the baby, right? So if my value is less than this, right, if my value is less than 60, less than 65, then I am going to give the oxygen to the baby. Okay, and next, like how you will give the oxygen? By through the oxygen tube, I can give by through the TPs, and I can give with a flow inflating bag. And next, oxygen is absent reservoir. So let me teach you the ambu bag first. So this is an ambu bag, artificial manual breathing unit, and this is the mask, and this is the self inflating the bag, and this is about reservoir, and this is about oxygen source. Okay, so now if my oxygen supply is absent, this one, and if my reservoir is also absent, so how much oxygen you can give to the baby is like 21%. Okay, and oxygen supply is there, this one oxygen supply is there, but this reservoir bag is not there. So then how much oxygen you can deliver? That is 40%. Okay, and next, oxygen supply is present, and both this reservoir is also present. Oxygen supply is also present, and both reservoir is also present. Then how much you can give? Like 90 to 99% of oxygen it can deliver. Okay, so very important slide, please go through this carefully. Oxygen supply is nothing but I showed you know the tubing, and reservoir is nothing but a flow inflating bag. If everything is absent, 21%. If oxygen is present and reservoir is absent, 40%. If both are present, they can deliver 90 to 99%. Okay, in the term baby, how much FiO2 you are going to give? That is 21%. In preterm, that is 30%. Okay, so this is very important. And rate at which you are giving this positive pressure ventilation is like 40 to 60 breaths per minute. Okay, and next, first breath, what is the pressure required during the first breath is like 30 to 40 centimeter of water. At recurrent or subsequently, you are going to decrease the pressure. So that is like at subsequent breath 15 to 20 centimeters of water. Okay. So like if anybody asks, absolute contraint, very very important to bag and mask ventilation is congenital diaphragmatic hernia. Okay. So this is the place where you are not giving this bag and mask ventilation to the baby. So why? Suppose imagine the air which you are giving by through the positive pressure ventilation is entering the baby. Okay. Air is entering, the air which is going to the trachea is completely fine, and the air which is going to the esophagus, air going to the esophagus. So what actually happens in this congenital diaphragmatic hernia, I am going to teach. You are giving this positive pressure ventilation, so air is passing. The air which goes for the trachea is absolutely fine, but the air which is going for esophagus, what it will do is like, here the intestine and everything is already, it is distended. The air will further distend it. No, the air will further pushes it. Air go to the stomach or in the esophagus. Air go to stomach and bowel loops. Okay. So that leads to the further mediastinal shift. Stinal shift. Okay. So what will be happen if the air, the lungs will not get proper space to expand. So there is a mediastinal shift over here. So that's why lungs will not get proper space to expand over here. So lungs will not expand. Okay. So this is why congenital diaphragmatic hernia, why I am not able to give the bag and mask ventilation. Okay. And next is like endotracheal tubes and their sizes. Okay, this is the very important table. So like if the baby weight is less than 1 kg and gestational age is less than 28 kg, so what is the size of an endotracheal tube you are going to use is like 2.5 mm. Okay, and 1 to 2 kgs it is 3 mm. At greater than 2 kg it's like 3.5 mm. So suction catheter size just double, 2.5 plus 2.5 it's 5, and 1 to 2 kg is 6 French, and it's like 8 French over here. Okay. So how do you confirm whether the endotracheal tube is in trachea or not? Is like by through the inspection. Okay. So like you just by looking at the chest movement is there or not, and by through the auscultation also you can do auscultation. And next confirmatory, which is the best thing, ETCO2. Okay, or you may call it as capnography. This is the best thing to know whether your endotracheal tube is in correct position or not. First, look at the carbon dioxide levels. Like if the tube is in trachea, if I expire, no, if I expel the air, if I expel the air from my trachea, it contains some carbon dioxide. If my tube is in the esophagus, no, the air is not present over there and I cannot expel the air, no. So that is the reason how this end-tidal carbon dioxide you are going to see in the capnography. The tracheal air in the expel, it will contain some carbon dioxide. If it is in the esophagus, it doesn't contain the air, no. So this is the mechanism behind it. And next we move to the chest compression. So what is the site of a chest compression? Where you are going to give is lower 1/3 of sternum. Okay, lower 1/3 of body of the sternum. Body of the sternum. Okay, so look at this. So which one? So now what I am going to, this is an finger technique, and this is about thumb technique. Okay, so how you are going to give? Draw a midline between the nipples. So which I will show you in the diagram. You should draw the midline between the nipples and you are going to give this chest compression to the baby. So finger technique nowadays it is no longer preferred. Okay, so this is not at all preferred nowadays. So this is a recent update. Don't go for this finger technique. Finger technique is not at all used nowadays, only thumb technique, because it has been shown that effectiveness is less in this finger technique and effectiveness is more in this thumb technique. Okay, this is the best preferred method. Okay, so where you are going to give this chest compression, 1/3 anterior posterior diameter, okay, of the chest should be depressed. So how many you are going to give? 3:1. Three chest compressions, and one breath you are going to give. This is the ideally which I am going to give. So like in 1 minute, how much I can chest compression I can give is 90 chest compressions. So what about the breaths? You can give 30 breaths per minute. Okay, so this is in the 1 minute. And next, like adrenaline dose. No, I thought like my heart rate is less than 60, I am going to give this adrenaline. So how much adrenaline you are going to give? 0.02 mg per kg per dose. If they ask you in terms of an ml, 0.2 ml per kg per dose. Okay, so this is the dosage of an adrenaline. And next, what is the dilution? 1:10,000 is the adrenaline dose you are going to use in the baby, right? In the neonatal research, very important. So how you gonna prepare this is like, normally this adrenaline vial is 1 ml, no? So like you take the 10 ml syringe, then put 9 ml normal saline and 1 ml of an adrenaline to this. Okay, so this is about how you are going to prepare ADR. Okay, very important. So how do you give this adrenaline? Yes, what is the best route? UVC, which is not umbilical vein catheterization. Okay, and next intraosseous. Okay, and next intratracheal. So nowadays, like it has been removed, intratracheal we are not at all using, so that's why I am not writing this. UVC, umbilical venous catheterization, or it is used in the intraosseous form. And resuscitation of a baby born through meconium stained. So very important, if the baby has meconium stained, so meconium stained babies are categorized into two types. One is your vigorous and one is your non-vigorous. In the vigorous, what you are going to do is heart rate. Look at the heart rate. If the heart rate of the baby is 100 and if the muscle tone is good and strong respiratory effort, then you can go as per the table, neonatal resuscitation program. If it is non-rigorous, do not stimulate. Do the endotracheal tube intubation and suction. And so this is like previously we are, so everything is absent. So look at the heart rate is less, muscle tone is less, and that is called non-vigorous. Okay, so you are not going to stimulate the baby and you are just put the endotracheal tube and suction. So this is the previous guideline. So the examiner, if they may ask if in the previous guidelines also, so that's why I am teaching. But nowadays what they have did, do endotracheal tube intubation, but at least one skilled person should be present in endotracheal tube intubation. So do not stimulate. Nowadays we are not stimulating in non-vigorous baby, like we are just putting an endotracheal tube. For putting that endotracheal tube, one skilled person should be present over here, and this is about recent updates. Okay, and like in which neonatal resuscitation is not performed, so that is like anencephaly. You are not going to perform this neonatal resuscitation. And in confirmed case of trisomy 13, okay, which is like Patau syndrome. And if the gestational age is less than 24 weeks, okay. So remember, like congenital diaphragmatic hernia is the where I cannot give this positive pressure ventilation. Now I am teaching you about where you should not perform this neonatal resuscitation. Okay. And next, cord clamping. So remember, always delayed cord clamping should be done to the baby. Why? Because like the blood will goes from the mother to the fetus, so that will reduces the fetal anemia and blood transfusion in the baby. So delayed cord clamping. So what do you mean? So what is the time duration that you should follow in delayed cord clamping? Is the time duration is 30 to 60 seconds, okay, after the birth. So previously, but nowadays in this recent neonatal resuscitation program, what they are going to do is like they have removed this 30. Okay, and now at least you should delay cord clamping at least for after 60 seconds only. You have to delayed cord clamping is performed. Okay, like after 60 seconds of birth. Okay, so to whom you are going to do? For all the stable term and preterm neonates. Okay, so what are all the advantages of delayed cord clamping? Advantages is like you will prevent the baby from anemia and hypotension and shock. Okay, and what is the disadvantage? There is a neonatal risk of jaundice. Okay, so this is about how you are going to do delayed cord clamping and all, right? So now remember, now I will teach this recent updates in neonatal resuscitation which it came in October. So I taught you, previously positive pressure ventilation. Now same you are going to give this positive pressure ventilation. Now that positive pressure, it has been removed and they are going to tell that ventilate the baby. Okay, now nowhere you use this positive pressure ventilation. You are going to use the term ventilate the baby over there. Okay, and this is one update, and one more update is like delayed previously 30 to 60 seconds, but now 30 has been removed. Now you are going to give until 60 seconds. Okay, and this is about recent updates. Then delayed cord clamping where you have to do on positive pressure ventilation. And one more update is like, look at this. Previously at 1 minute you have to check the SpO2 of the baby, but recently I will rub this, they have removed this 1 minute. Okay, they have removed this 1 minute and then you are going to check the SpO2 at 2 minutes. Okay, so this is about recent updates like neonatal resuscitation. I think most of you have cleared about this until now. I think until now everything is fine. I think now everything is fine. Dose and chest compression. So I taught you, like what do you, the dose you are going to use, like 0.02. So this is the dose 0.02 mg per kg per dose and 0.2 ml per kg per dose, and the dilution is 1:10,000. Okay. And breathing and chest compression. So same like 3:1 in neonates or in a newborns, like 3 times I use the chest compression, at one time I will use this ventilate the baby. Okay, and dose and chest compression I have did, and breathing and chest compression. Okay, and this is also fine, this is also fine. Okay, and next, if you have any doubts, and this is about neonatal resuscitation, very important topic, so please go through this very carefully. I have simplified for you. And now let's solve the MCQ. According to neonatal resuscitation protocol, how much oxygen should be given to a term neonate with apnea? Tell me how much oxygen should we are going to give? So for term baby, FiO2, how much you are going to give? Is like 21%. No, I have explained it earlierly also. Look at this. According to neonate, how much oxygen should be given to a term neonate? For term neonate, I am going to give 21%. Okay, so remember very carefully, for term babies 21%. If the baby is preterm, then your FiO2 value will be 30% over here. Okay, and next, when do you consider administrating epinephrine to a neonatal resuscitation during neonatal resuscitation? So when you are, very important question, like question is very big but the answer is very simple. Like when you are going to give this epinephrine, so I will keep on repeating so that you won't forget. Like epinephrine 1:10,000 dilation, 0.2 ml per kg, 0.02 mg per kg. Okay, so I taught you the preparation also, how you are going to prepare. And like, look at the heart rate. My heart rate is less than 60, I am giving epinephrine. Yes, this is absolutely fine. So heart rate less than 60, you have to give the epinephrine. So this is fine. and heart rate remains at less than 100. No, despite effective compression and ventilation. Like heart rate less than 100, like after giving positive ventilation, I will check for the ventilation corrective steps in this question. Steps, okay? And heart rate does not improve after 30 seconds with bag and mask ventilation and all. Over here, yes, tell me. No, here also I use this corrective steps. So here I will use this corrective steps over here. And infant with severe respiratory distress who do not respond to the positive pressure ventilation via bag and mask. So look at this. Infant with severe who does not respond to positive pressure ventilation via bag and mask, what you are going to give is like, I am going to give this chest compression, and next I am going to give epinephrine. Okay, so heart rate less than 60, the key point over here is heart rate less than 60, you have to give the drug that is epinephrine over here. Okay, okay, I think like everything is fine. So today I hope like we had some technical glitch so that most of the students they could not join. So we'll apologize for that, and definitely we'll improve. So like next sessions will be on like pediatrics. First we will cover our pediatrics, and next we move on to MCQs, and next we move on to the others. So we'll cover the subject wise. So exam is very near. So I will be taking like ultra rapid revision courses for you guys. So that will be very beneficial for you, along with the test series and along with the MCQs and all. So thank you for hearing guys, and keep studying. And if you have any doubts in this today's class, you can contact us at any time by through our WhatsApp channel and by through our these Instagram ID also. Like our channel Instagram ID is at MEDCATALYST MEDCATALYST, and you can contact me in, and you can drop your message and in your my WhatsApp group also. So I will be responding to your questions, like for any of your queries I will be attending personally. Okay, I think now everything is fine. Everybody are thorough about neonatal resuscitation. This is very important. Please go through this very, very carefully. Okay. So today class, most of the students, sorry for that. I will apologize for that. Like due to some technical errors, we could not start the class as early as possible. Okay, and thank you guys, and thank you for hearing, and keep studying, and we will be coming up with further sessions. So please attend the sessions carefully. Definitely you will get a seat.